Good morning, batch 24. How everybody this morning? I hope everybody is in a good health and stay at home always. For today, we have an topic on epidemiology and public health aspect of oral cancer, which consists of two parts. For today, I will do the part 1, and the next week we'll do the part 2. Right? So, okay, these are some of the pictures of appearance of oral cancer. You have the red patches on the tongue, side of the tongue, on the buccal mucosa. Maybe we have the lichen planus, the white patches on the buccal mucosa, and you have white patches on the lateral aspect of the tongue, and the white patches also on the ventral aspect of the tongue. And the last picture is you see is what we consider as squamous cell carcinoma of the label parts of the alveolus. Okay, the learning outcomes that you expected from everybody is at the end of the topic. The student should be able to identify risk factors of oral cancer, explain the various public health aspects of oral cancer. The third one is prevalence oral cancer in Malaysian populations. The fourth one is discuss the preventive strategies of oral cancer and describe the various methods to reduce tobacco use. The last two learning outcomes we will do in part 2 of the lectures. Okay, as an introduction, we have the what you call characteristics of cancers, oral cancers. It can be described as one is clonality. What do you mean by clonality? Cancer originates from genetic changes in a single cell, which proliferates to form a clone of malignant cells. Okay. Second one is autonomy. What do you mean by autonomy? Growth is not properly regulated by the normal biochemical and physical influences of the environmental. There is an irregular growth of cells that cause cancer later. Okay. The third one is anaplasia. Anaplasia, there is a lack of normal coordinated cell differentiations. Right, and the fourth one is metastasis. Metastasis can be defined as cancer cells develop the capacity for discontinuous growth and dissemination to other parts of the body. Under leukoplakia, you can define it as a raised white part of an oral mucosa measuring about 5 mm or more, which cannot be scraped off and which cannot be attributed to any other diagnosable disease. But this definition does not carry any histologic connotations. It is the most important precancerous lesion in terms of being the most common as well as being the point of origin for most oral cancers. The global prevalence of leukoplakia has been reported to be about 2.6%. Erythroplakia, you can define it as a red lesion of the oral mucosa that cannot be characterized as any other definable lesion. The lesion appears as an eroded red area with a distinct demarcation against the normal appearing mucosa. It has been associated with reverse smoking. The global prevalence of erythroplakia has been reported to be in the range of 0.02 to 0.1% globally. And the lichen planus, the etiology of lichen planus involves a cell-mediated, immunologically induced degeneration of the basal cell layer of the epitheliums. The prevalence varies from 0.5% to 2.2%. The risk of malignant transformation is low and does not exceed an incidence of 0.2% per year. Okay, and associated of oral lichen planus is an association of oral lichen planus, diabetes mellitus, and hypertension. Triad is referred to as Greenspan syndrome, which predispose to the development of squamous cell carcinoma. And okay, submucous fibrosis. Submucous fibrosis is a chronic disease that affects the oral mucosa as well as the pharynx and the upper two-thirds of the esophagus. The global incidence is estimated at 2.5 million individuals. Malignant transformation is estimated to be in the range of 7 to 13%. Now we go to malignant transformation of oral precancer lesions. Actually, it's difficult to predict from clinical appearance, right? And oral epithelial dysplasia. Epidemiological triad. The host is, we have the host, we have the agent, and we have the environment. We look at the host now. The host could be the age. What about the age? Actually, oral cancer is more dominance in the higher age group. That means 50s and above. Race is due also to the habit, alright, and Indian due to the habit have a higher chance of having oral cancer. Gender, males due to the habit also have a higher incidence of oral cancer. Genetic factors oral cancer is not due to genetic factors, but others like stomach cancer, it may be due to genetic factors. Occupations, of course, it affect your environment. Immunity, this is normally if you have low immunity, you are very prone to have cancer, especially those in HIV cases. Social class, of course, the lower social class, they have habits of that cause them to have a higher chance of oral cancer. Then customs and habits also have a higher chance of people to have oral cancer. And the agents, we have biological agent, there is virus, HIV, EPV, and HSV. Fungus, Candida fungus. Okay, chemical, you have arsenic, dyes, nickel, aromatic, amines, and chromium. Under mechanical, you have sharp tooth, ear filling, prosthesis, or dentures, or chronic sores. Okay. Nutritional, you have carcinogens in food, increased consumption of fat and spicy food, deficiency of proteins, folic acid, and antioxidant vitamins like vitamin E and vitamin C. Environment, water contamination, organic pollutants, chloroform, example chloroform, air pollutions, geographic variations, industrialization. Etiology, there are two etiologies, non-modifiable risk factors, like the gender, male to female ratio is 4:1, ethnicity, black to white, immune system deficiencies, age, and genetic predispositions. Then modifiable risk factors or behavioral choices. Tobacco and alcohol. What is the relationship between oral cancer with tobacco and alcohol? Okay. Synergistic effect between tobacco and alcohol. Okay. Dehydrating effects on mucosa and increase mucosal permeability that easily cause carcinogenic agents to enter the mucosa, our mucosa. Then you have the various forms of tobacco, which is very dangerous. Smoking tobacco, bidi, chillum, chuta, cigarettes, damti, hookah, and hockey. Smokeless tobacco, you have tobacco chewing plug, loose leaf, chimo, tombak, kaini, Mainpuri tobacco, mawa, mishri, pan, snuff, shamash, nas, and naswa. There's a different preparation of tobaccos that is very dangerous. Okay. Then, this is the content of cigarettes. Do you know what the content of the cigarettes? 42 non-carcinogens and 400 compounds that is present in one piece or one cigarette. Okay, it includes stearic acid, cadmium, nicotine, toluene, ammonia, paint, methanol, carbon monoxide, arsenic, methane, and acetic acid, plus butane. All these are carcinogenic agents for oral cancer. Alright, and smoking tobacco, BDs. Okay, BDs. About 0.2 to 0.3 grams of sun-dried tobacco flakes are hand-rolled in a rectangular piece of tenbuni or tendu leaf and tied with a thread. About 60% of the weight of the BD is made of the leaf wrapper. Okay. And then we have chillum. It is a straight 10 to 14 cm long conical clay pipe used for smoking tobacco. The chillum is held vertically, and to prevent tobacco from entering the mouth, a pebble or stopper is introduced into the chillum. It is filled with coarsely cut tobacco pieces, and a glowing charcoal is kept on top of the tobacco. And then you have chuta, a somewhat cylindrical, coarsely prepared cheroot. Cured tobacco is wrapped in a dried tobacco leaf. Okay. About 9% of the total tobacco production in India is used for the preparation of 300 million pieces of these forms of tobacco. Cigars are made in air-cured fermented tobacco, usually in modern factories. Okay. And then you have cigarette, you have hookah, you have dumpty. Cigarette, you know, is a big money for cigarette companies. Okay. Hookah, what do you have? Hookah. Hookah, it is called water pipe or hubble bubble. It is used in place with a strong Mongol cultural influence. Hookah is purely of Indian origin, which corresponds with the introduction of tobacco in India. The tobacco is smoked in drawn. The tobacco smoke is drawn through the water in the base of the hookah, which cools and filters the smoke. Okay. Dumpty, they are somewhat conical cheroots. Okay, raw leaf tobacco is used inside a leaf of jackfruit tree. Sometimes dry leaf of the banana plant is used. This form of tobacco is occasionally used for reverse smoking, especially among women. Okay, smokeless tobacco, what do we have? Kaini, Mainpuri, chewing tobacco, and Mawa. And you have Mishri, snuff, and pan. Okay, magnitude and extent of oral cancer. Worldwide, smoking accounts for 42% of deaths from cancers of the oral cavity, including the pharynx. In total, tobacco use is responsible for the death of about 1 in 10 adults worldwide. Tobacco use is a major cause of many of the world's top killer diseases, including cardiovascular disease, chronic obstructive lung disease, and lung cancer. Smoking is often the hidden cause of the disease recorded as responsible for death. Smokeless tobacco products and bitter quick, with or without tobacco, are the major risk factors for oral cancer in Taiwan, India, and other neighboring countries. The rise in the incidence rate of oral cancer in Taiwan may have been in part due to the increased consumption of bitter quick and alcohol. The corresponding percentage in high-income countries are about 70% and 30% respectively. Okay. Etiology, one is infections. Modifiable risk factors or behavioral choices. One is human papillomavirus, herpes simplex virus, Epstein-Barr virus, and chronic hyperplastic candidiasis. Human papillomavirus. Some of these cancers contain the most dangerous HPVs, 16 and 18, are transmitted through sexual contact. Oral cancers, an increase in patients with little or no history of smoking or drinking, were reported by physicians. However, incidence risks for oral cancer sites related to HPV infections, such as the oropharynx, tonsil, and base of the tongue, are increasing in young adults in the United States and in some countries in Europe, which is hypothesized to be in part due to changes in abnormal sexual behavior. And it has come to Malaysia at a dangerous rate of behavior. Oral cancer trend in Malaysia. Recognized in 1960s, prevalence is about 0.04%. High frequency found among the Indians and indigenous group of Sabah and Sarawak. In Malaysia, the National Cancer Registry reported that for year 2003 to 2005, oral cancer is ranked 22nd and 15th most common cancer among males and females in Peninsular Malaysia. Public health issues. It is evident from the results of Global Adult Tobacco Survey that tobacco consumption is still a major public health problem in Malaysia. About a quarter of Malaysians smoke tobacco, 43.9% of men and 1% of women. In addition, a daily cigarette smoker smokes an average of 14 cigarettes per day. In Malaysia, tobacco use accounts for a massive 35% of in-hospital deaths, with 3 out of the country's 5 leading killers accounting for a large share of these deaths. What are the 3 leading cause of death? That is cancer in other parts, heart disease, and stroke. In Malaysia, more than 10,000 Malaysians die from smoking-related illnesses every year. Smoking in Malaysia. Approximately 1 out of 2 Malaysian men smoke. Okay, this translates to 7 million Malaysian male smokers, with Malaysian population 27 million. Okay, 3 out of 10 of adolescent boys smoke. That is age 12 to 18. Okay. According to studies on teens conducted in 1996 and 1999, the numbers of female teen smoking rose from 4.8% to 8%. Okay. Overall, the 1999 study found nearly 1 in 5 teens smokes. Okay. Studies show that lung cancer is rising at the rate of 17% a year. Okay. 5 most common cancers or residents Malaysia 2007. Breast cancer among the highest type of cancers, 18.1%. Head and neck, 13%. Colorectal, 12%. Trachea, bronchus and lung, 10%. And cervix, uteri is 4.6%. 10 most frequent cancers in males by ethnic groups, Peninsular Malaysia, 2006. Indian, colorectal, 11.6%, prostate gland, 13.3%, lung, 8.23%, stomach, 7.2%, bladder, 5.2%, tongue, 4.6%, esophagus, 4.5%, larynx, 4.5%, liver, 4.1%, and kidney, 4.1%. 4%. Okay. 10 most frequent cancers in females by ethnic groups, Peninsular Malaysia, 2006. Indian, breast cancer still highest is 30%. Uterus, cervix is 8.2%. Colorectal, 7.8%. Mouth, it has come up as 7.3% of all cancers. Ovary, 5.1%. Thyroid gland, esophagus, lung, corpus luteum, and stomach is around 3%. Preliminary NCR reports 2007. Okay, we have sight, lips, mouth, tongue, and total. Stage 1 for lip, we have about 6 cases. Stage 2, about 2 cases. And stage 3 is about 1 cases. And stage 4, about 1 case. For mouth cancer, for stage 1, we have about 10 cases. Stage 2, about 13 cases. Stage 3, 18 cases. And stage 4 is 53 cases. Okay. For tongue cancer, we are detected at stage 1 about 10 cases. Stage 2 is more, about 25 cases. Stage 3, 24 cases. And stage 4 is much more, it's about 40 cases. Total number of cases we detected at stage 1 is about 26 cases. Stage 2, about 40 cases. Stage 3, about 43 cases. And stage 4, surprisingly, we have about 94 cases. For the total number of registered cases is about 369, but total number reported with staging is about 203 cases. But staging for all cancer types, Malaysia 2012-2016. This is the latest report by NCR. Sides, lips, they're divided into male and female. Okay, we go into male first. At stage 1, for lips cancer, we have about 4 cases that was detected at stage 1. Stage 2, about 4 cases. Stage 3, 3 cases. In stage 4, we have 2 cases. For lip cancer for female, we detected at stage 1, so about 10 cases. Stage 2 at 9 cases. And stage 3, about 8 cases. And stage 4, about 7 cases. Surprisingly, for tongue cancer, for male, we detected at stage 1 is about 62 cases. Stage 2, about 70 cases. Stage 3, about 75 cases. And stage 4, we have about 149 cases. 149 cases. Female tongue cancer also is on the increase. At stage 1, we have about 46 cases. Stage 2, we have about 69 cases. At stage 3, we have about 53 cases detected. And we detected tongue cancer for female at stage 4 is about 116 cases. Okay. For other region other than lips and the tongue, we considered it as the mouth cancer. This includes all the epithelium of the mouth, buccal and lingual epitheliums. Right? And we have for male, number of mouth cancers that was detected at stage 1 is about 25 cases. Stage 2 is 45 cases. Stage 3, 45 cases. But stage 4, we have about 122 cases. For female, stage 1 is about 42 cases. Stage 2, we have 60 cases. Stage 3, we detected about 54 cases. And stage 4, we detected about 130 cases. I included the salivary glands cancer in this. We have male for detected at stage 1 is 22 cases. Stage 2, 22 cases. Stage 3, but 29 cases. And surprisingly, at stage 4, we have 61 cases. For female, salivary glands cancer for female, we detected at stage 1 about 26 cases. Stage 2, 39 cases. Stage 3, 21 cases, and stage 4, 51 cases. Overall, total number of cases registered is 2,225 for these four sites of cancers, but the number registered at stages is only about 1,480 cases. From this staging, we can see that all the cancers are detected at a higher level in stage 4. Okay, especially the tongue and the mouth cancers. And it is at an alarming number of cases. Right? And female number of tongue cases also is very high, as well as mouth cancers, female. What are the cause? What are the problems? We have to find out, and we have to see what can be done about this. Surprisingly, number of cases of female smoking also increase in numbers. Right? So with that,